Welcome to Holmes on Health, the podcast where nutrition, fitness, and hormones meet health span, and science meets real life. I'm Dr. Alan Holmes, a recovering emergency physician turned expert in hormone optimization, metabolic wellness, and living life fully optimized. Each week, we dive into the tools, truths, and evidence-based therapies that help you build a stronger body, sharper mind, and more vibrant life. Whether you're curious, confused, or already optimizing, you're in the right place. Thank you for being here. Let's get into today's episode. Hello, and welcome to this episode of Holmes on Health. I'm Dr. Alan Holmes. In 2002, there was a single press conference that changed the way the world viewed hormone therapy. The headlines declared that estrogen and progestin hormones were dangerous, that they caused breast cancer, that they increased risk of heart disease, that they caused strokes, amongst other problems. And overnight, millions of women stopped using their hormones. Doctors became afraid to prescribe hormones. But what if that wasn't true? What if those headlines were misleading? What if the results were much more nuanced than that? And that the way they were released shaped decades of women's health through creating fear? This week, we're going to unpack the truth about the Women's Health Initiative study, what it really found, and what we know to be true about the safety and benefits of hormone replacement therapy today. So thanks for being here. Let's get into it. So let's start with what was the WHI. It was the largest, most expensive women's health study ever conducted. The cost is estimated somewhere between $600 million and $1 billion. The exact figure's never been landed on. But whether it was $600 million or whether it was $1 billion, the sheer cost of it lets us know that it's never going to be repeated. The trial was designed to determine whether postmenopausal hormone therapy should be offered to all women to reduce the incidence of cardiovascular disease. Now, given the relatively low incidence of cardiovascular disease, or cardiovascular events, I should say, in younger women, an older group of women was actually who was recruited to be in the study. The average age was 63 years old. So there's three groups of women in the study. The first group, what we'll call the placebo group, received no hormone therapy. The second group was a group of women that had a hysterectomy, and therefore they only received estrogen therapy in the form of Premarin, or conjugated equine estrogen, from pregnant mare urine, but they did not require a progesterone of any type because they did not have a uterus to protect. The third group of women that were enrolled, there was over 16,000 of them, had not had a hysterectomy, therefore had a uterus to protect. And so they were given Premarin plus medroxyprogesterone acetate, which is a synthetic progestin, brand name Provera. The combo drug of Premarin plus Provera is known as Prempro. This is the group that made the headlines. This is the group that provided all the panic, or caused all the panic. And so this is the group that we're going to focus on. So before we get into the details of the WHI, I think it's worthwhile to step back a bit further and talk about what was the literature saying prior to the WHI? And I'm just going to run through a few examples of articles that address this. There are many, many more, so this is in no way an exhaustive list. We'll start 1986. There was a study done by the National Cancer Institute that found that there was no statistically significant increase in the risk of breast cancer among women that were on Premarin, even after they'd been on for at least 20 years. In 1988, there was a meta-analysis where they looked at 22 different studies. It was done at the Research Institute in Epidemiology and Prevention Medicine at the University of Western Australia. And it found there to be no statistical association between estrogen replacement therapy and breast cancer. In 1991, there was a study at Boston University School of Medicine that found there was no increased risk of breast cancer among Premarin users even after 15 years of use. In 1992, there was a randomized, double-blinded, placebo-controlled trial. This is the gold standard of research that showed that 11.5% of women taking placebo that developed breast cancer, and there were no women that developed breast cancer that were on HRT. So let me state that more clearly. They took two groups of women and they tracked out who's going to get breast cancer and who isn't going to get breast cancer. And it showed there was an 11.5% incidence in the placebo group and a 0% incidence in the HRT group. The consensus amongst all the major journals and leading oncologists was that estrogen did not increase risk of breast cancer. In 1993, there was an editorial in the New England Journal of Medicine by endocrinologist Catherine Martin and Mason Freeman of the Massachusetts General that said, and I quote, "On the basis of the available evidence, we recommend that all postmenopausal women be considered candidates for hormone replacement therapy and be educated on the risk and benefits." Then in 1995, a report results of the Nurses Health Initiative study came out. This involved over 121,000 female registered nurses. They had been followed from 1976 up until 1992, and they found that there was no increased risk of breast cancer compared to the women who had never taken hormone replacement therapy. In 1996, a study of 422,000 women conducted at the American Cancer Society found that those that had ever taken any type of estrogen replacement therapy had a small but significantly decreased risk of dying of breast cancer. To be fair, there was other literature. There were some negative studies. Let's look at one here. 1989, New England Journal of Medicine published a study studying the women of Uppsala, Sweden, and it showed a 440% increase in breast cancer. So let's look in a little more detail. This study looked at 23,000 women. Well, it actually looked at their prescription forms. And this was the entire female population of Uppsala that was on estrogen replacement therapy or hormone replacement therapy. But they didn't look at all the records. They just took a sampling for sake of time and energy. So they studied about 1 in 30 women. Then they found a subset of those women that totaled about 638 who had filled out 2 questionnaires. And in those findings, they found this. There was no increase in breast cancer in the estrogen alone group. And then in some smaller group of the 638 who were taking estrogen plus progestin, a group in which they calculated there should have been about a 2.2 incidence occurrence of cancer, but they found that there was a 10 incidence of cancer. And that is a 440% increase. Now, interestingly, in that paper, the researchers concluded the results were not statistically significant, meaning there were too few patients that they looked at and they couldn't make sense of a 440% increase, meaning in studies, if it's not significantly powered, if there are not enough numbers, enough patients, enough data points, then false conclusions can come out of the numbers. In a follow-up to that study that was released not long after the article was released, the researchers actually reported a better prognosis among the breast cancer patients who were on estrogen at the time of diagnosis than those who were not. There was an editorial that followed this up in the New England Journal of Medicine by a Dr. Elizabeth Barrett Connor, and she wrote, "For the average North American woman who will be postmenopausal for a third of her life, the benefits of estrogen seem strongly established. Quote, in my opinion, the data are not conclusive enough to warrant an immediate change in the way we approach hormone therapy." End quote. Now, let's move to the summer of 2002. It's June 27th, Chicago. The 40 principal investigators in the Women's Health Initiative flew into Chicago, Illinois for a meeting at the Sofitel Hotel. Now, at this meeting, they were expecting to get an update on the recruitment of patients, the lab reports, maybe some updates on the safety notes. Instead, they got something far, far different. They entered the room, they all sat down, the lead investigator comes in, and then without much build-up at all, makes an announcement and says, "We're stopping the estrogen plus progesterone arm of the study. We're stopping it early because there is an apparent increase in breast cancer along with heart disease and strokes." The part that most people never heard was this. JAMA, the Journal of American Medical Association, had already accepted a paper for publication. The study's conclusions were written and already set to go to press. This was without the input of the 40 principal investigators. They, while in the room, were given proof copies of the article that had already been written to look at. Years of work, the public's perception was about to be decided in literally a matter of minutes. So these investigators are sitting there, they're flipping through the pages of the article. They can't believe what they're reading. They are noticing that the increases were all relative numbers. They weren't absolute numbers. They looked at the study population and found it was much older than the average women that started hormones. Yet there was no time for thorough discussion. They tried to refute. They tried to raise concerns. They raised the concern that this article that has been written has not yet been peer reviewed, and we would like to review it as the investigators. And they said, sure, take the next 60 to 90 minutes. Some of them just completely frustrated because this is not how the scientific process goes. It's not how it's supposed to work. Some of them actually tried to go through and try to redact part of the article and edit part of the article as feverishly as they could. After about an hour and a half of work, they turned in their edits. A courier was called, took those edits, couriered them across town to where the JAMA publication was happening. And then the courier returned and said, it's already gone to press. It's too late. Less than 2 weeks later, National Institute of Health held a high-profile press conference in Washington. Reporters are packing the room, and the message was short, it was direct, and it was alarming that hormone therapy increased the risk of breast cancer, heart disease, and stroke. The benefits of reduced fractures, of lower colon cancer, barely even got any coverage at all. The nuance was gone. By the time the JAMA article actually hit the newsstands, the headlines were already locked in, and the generation of women had been told hormones are dangerous. Here's an example of a few headlines from publications at the time. Time magazine wrote, the truth about hormones, HRT is riskier than advertised. What is a woman to do? The BBC wrote HRT linked to breast cancer. New York Times wrote hormone replacement study a shock to the medical system. In the weeks after this, prescriptions plummeted by 79%. Women flushed their pills or patches and their creams down the toilet. Many of them with symptoms suffered in silence. And for years, the fear that was created in those few minutes in Chicago, the decisions that were made, shaped the way doctors and patients approached hormone therapy even to this day. So what did it actually say? The estrogen plus progesterone group had a small increased risk of breast cancer, 1.26, when compared with women who were randomly assigned to the placebo group, meaning the group that got no hormones. Now, what does 1.26 means? That means that there was a 26% increase in risk of breast cancer. Now, here's the sentence that is clearly written in the paper in black and white, but did not make it to the media headlines. Quote, the 26% increase in the breast cancer incidence in the hormone replacement therapy group compared with the placebo group almost reached nominal statistical significance. Almost reached, meaning it did not reach statistical significance. And in the research world, what that means is it could have very well happened by chance. It could have just been something in the numbers. But even if it was statistically significant, and it wasn't, but even if it was, the increased risk of breast cancer would have gone from 5 cases in 100 women to 6 cases in 100 women. The absolute risk was less than 1 in 100. And let's not forget that the study also showed, although unfortunately not picked up in the media, that women diagnosed with breast cancer while taking hormone replacement therapy had a better prognosis than the women diagnosed that were not taking hormone replacement therapy. Let's fast forward to 2006. Update is released on the Women's Health Initiative study. It reported that they found no increased risk of breast cancer among the very same women. So the alleged increased risk, the one that stopped the study early, now had completely vanished. Now, it's curious that the news didn't pick up on that headline. It's as if they treated the bad hormone news much differently than they treated the good hormone news. There's one other thing to point out here. In the placebo group, there was an unusually low breast cancer incidence compared to the general population. It was especially lower in the participants who had previously been on hormone replacement therapy, which was some 25% of those in the study. Now, instead of asking why the placebo group's breast cancer incidence was so low compared to that with the placebo groups in the rest of the WHI study, the authors chose to focus on the treatment arm, which breast cancer incidence was no different than the never users, meaning those that had never been on hormone therapy. In fact, and this is quite interesting, it was found to be similar or sometimes even lower than the risk associated with other factors like obesity, low physical activity, and, don't shoot the messenger, those drinking 2 glasses of wine daily. So let's go through just a few other findings. In the Premarin-only group and the Premarin plus progestin group, it showed an increased risk of blood clot strokes and pulmonary embolisms or blood clots to the lungs. This risk seemed to be increased with age. This risk was much greater in the Premarin plus Prem group, meaning those on combo therapy. The conjugated equine estrogen plus the conjugated equine estrogen and progestin group showed an increased risk of cardiovascular events. This is where they got that it increases risk of cardiovascular disease. Although this was only shown in the first year of the study. In years 2, 3, 4, and 5, the incidence went down. In fact, by year 5, it appeared that it was protective against cardiovascular disease. So where are we now? What was studied in the Women's Health Initiative trial was Premarin, conjugated equine estrogen. Now, let me stop here and just make sure we know what we're talking about there. What does conjugated equine estrogen mean? It is sourced from the urine of pregnant horses. There are actually 14 different types of estrogen in conjugated equine estrogen. Only a handful of those are actually known to the human body. So that's an important distinction to make. We know now that Premarin, conjugated equine estrogen, is far more active in increasing inflammatory markers like C-reactive protein, as well as inducing an enzyme called matrix metalloproteinase 9. Now, why is this important? Because it is a potent enzyme that breaks down collagen. So let's make a connection. The early increases seen in the WHI of cardiovascular events are attributed to plaque destabilization and rupture. So what does that mean? Well, let's look at what is a heart attack. A heart attack is a rupture of a plaque in the coronary artery that supplies blood to the heart. So if a plaque forms through risk factors of cardiovascular disease, smoking, cholesterol, diabetes, high blood pressure, all of these things cause micro damages to the tissue in the wall of the artery. Over time, as those micro damages are repaired, they create a plaque. That plaque is formed of collagen. So if we introduce something that can break down that collagen, like matrix metalloproteinase 9, then the more collagen it breaks down, then the plaque gets more vulnerable or has an increased risk of rupturing. When a plaque ruptures, that causes an injury that causes the attraction of platelets, which create a clot, and that is what a heart attack is, meaning that is what is the cause of a cardiovascular event. So we have women that have potential plaques in their arteries. We give them Premarin, which therefore increases the amount of matrix metalloproteinase 9 that is circulating in the bloodstream, that then breaks down that collagen or that plaque, leading to its risk of rupture. So they said that hormones, Premarin and Prempro, cause an increase in cardiovascular disease. What they were saying was that it caused an increase in cardiovascular events, meaning plaque ruptures, which is why it only occurred in the first year. Because if you had a rupture, yes, that plaque could have ruptured. But if you didn't have a rupture, and let's presume, and what we know is that hormone replacement therapy actually lowers risk of cardiovascular disease through multiple mechanisms, then in year 2, 3, 4, and 5, there was a decreased risk of cardiovascular events because there was a decrease in plaque rupture, because there was a decrease in plaques. I hope that makes sense. That was a lot. And we're in a future episode, we're going to go take a deeper dive into how all that pathophysiology works. But I just wanted you to know, why are they saying it causes heart attacks and what do they really mean by that? So that's an important distinction. So the second thing is synthetic progestins have a unique receptor binding ability. Now, what do I mean by this? A synthetic progestin, meaning medroxyprogesterone acetate, binds to receptors at a much greater affinity than natural bioidentical progesterone, meaning they're hold on to the receptor longer than they're supposed to. And therefore, the results of that, the signaling of that, is abnormal, and then abnormal things happen, such as a potential increased risk in adverse metabolic events. We know that medroxyprogesterone acetate increases insulin resistance. We know that it increases risk of thromboembolism, such as blood clots. because when they compared the incidence of blood clots to that group versus a group that did not get medroxyprogesterone acetate, there was more blood clots in the group that did. This is an important distinction. These synthetic hormones do not behave like bioidentical hormones. And what was studied in the Women's Health Initiative were no bioidentical hormones. So what have we learned? The WHI did teach us some very valuable lessons, but the way it was resulted, the way it was communicated, caused unnecessary harm. The science today tells us a vastly more hopeful story, that in the right patients and the right hormones, therapy can be safe and life-changing. What do I mean, right patient, right hormones? The distinction cannot be overstated that the WHI studied synthetic hormones, not bioidentical hormones. It did not study 17-beta estradiol, which is but the bioidentical active form of estradiol that circulates in the body. And it did not study micronized bioidentical progesterone. And there is a plethora of literature that exists that study these molecules, and none of them show an association with an increase in breast cancer, with an increase in venous thromboembolisms or blood clots, or strokes, or heart attacks. They do show a marked and statistically significant positive effect on each of these things: breast cancer, cardiovascular events, colon cancer, fractures, and overall mortality. In a upcoming episode, I'm going to take a much deeper dive into all the benefits from bioidentical hormones that the literature shows for women that are postmenopausal. For now, the takeaways are these. I don't want you to take outdated headlines and use them to define your health choices. I encourage you to ask questions. Do your research, ask your doctor, start this conversation. They should be more than willing to have it with you. They should not say the literature shows that hormones are bad, because as we just talked about, that's not what the literature showed. The nuances matter. So takeaways: Women's Health Initiative study, poorly designed study, poorly executed study, poorly interpreted study. And that has unfortunately significantly harmed the health of over 2 decades of women. Some of you are those women. Some of your mothers were those women. And I sincerely apologize as a member of the medical community that has happened to you, because it shouldn't have. And the part that frustrates me the most is that the megaphone, the huge microphone that they used to herald the story that hormones were bad, they refused to use to tell you that they were wrong. The authors of the study have since come out and said some of the conclusions were poor. Some of the conclusions of the WHI do not appear to be as we thought they were. Perhaps we should redo the study. Again, it was $1 billion study. I can't imagine it's ever going to be redone. But my issue with them is that they didn't come out with the same veracity of conviction saying we were wrong as they did telling women they had to stop and telling doctors it was malpractice if they continued to prescribe. So even if they admit that they're wrong, they're not doing it in a way that really moves the needle. And in medicine, it is so hard to move the needle. And this is an example of one of those areas. The other difficulty of this is that providers today, particularly obstetrics, OBGYNs, they are giving minimal, if any, education on hormone therapy during their residency training. Doctors that specialize in women's health are not educated on how to optimize their health. That's a travesty. They are essentially said, it's menopause, it's part of life, we don't know what we should do, maybe take this or that for a little bit of symptom relief. And that is unfortunate. Now there are a handful of OBGYNs and primary care physicians that are beginning to get on their soapbox, and they are beginning to recognize the wrongs that were resulted from the WHI, and are beginning to stand up and raise their hand and say, hey, we were wrong. That's not what the literature actually says, and are beginning to actually advocate for and actively treat women for menopausal symptoms, both symptomatically as well as what's happening to their overall metabolic health in terms of heart health, bone health, brain health. And I think that is outstanding. Is it moving fast enough? Absolutely not. But the fact that it's starting to happen is encouraging. So I say that to say that if you are a woman in menopause, number one, the WHI trial was wrong. Number two, your provider should know that. And number three, if they don't, I think you should find a different one, because the benefits it can provide you, both symptomatically as well as quality of life, as well as longevity, are irrefutable at this point. And so I would encourage you to have this conversation with your doctor. If they won't have it, I encourage you to find a different doctor. I hope that you found this information helpful. I hope it perhaps answers some of your questions about the safety of HRT or what all the fear was about. And I hope, my biggest hope is that maybe it helped alleviate some of your fears. If it was, please share it. I'd like to hear your comments, what your thoughts are on this, any questions I didn't answer that I could answer better in the future, and share it with someone you think may benefit from it, a family member, a friend. And lastly, I would ask you to subscribe to the channel, leave a review because that helps other people find the podcast. And then until next time, live life optimized. Thank you for tuning into this episode of Holmes on Health. If you found today's episode valuable, share it with someone you care about. And hit subscribe so you never miss a future episode. Want to get more of our content? Follow me on Instagram and YouTube at Alan J. Holmes MD. Until next time, here's to living life optimized. This podcast is for general informational purposes only and does not constitute the practice of medicine or other professional healthcare services, including the giving of medical advice. And no doctor-patient relationship is formed. The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions.